Assalamu alaikum and welcome to the Medical Black Book. Our today's topic is post-operative care. Post-operative period begins from the time the patient leaves the operating room and ends up with follow-up visits by the surgeon. The post-operative care is provided by PACU. PACU stands for Post-Anesthetic Care Unit. In this, the patient is still under anesthesia or recovering from anesthesia are placed in this unit for observation by highly skilled nurses, anesthetists, and surgeons. The PECU should be soundproof, painted in soft color, isolated, and these features will help the patient to reduce anxiety and promote comfort. The purpose is to enable a successful and faster recovery of the patient in the post-operative period, to reduce post-operative mortality rate, and to reduce the length of hospital stay of such patients, to provide quality care services, and to reduce hospital and patient costs during post-operative period. They have two phases, phase 1 and phase 2. Phase 1 is the immediate recovery phase and requires intensive nursing care to detect early signs of complication. It also receives a complete patient record from the operating room to which the plan post-operative care is based. It is designated for care of surgical patients immediately after surgery and patients requiring close monitoring. Phase 2. In this, there is a care of the surgical patient who has been transferred from phase 1 to post-op unit. Patients requiring less observation and less nursing care than phase 1. This phase is also known as step-down or progressive care unit. If any complications can occur in this phase, the following are listed. The first one is basically the respiratory complication. In this post-operative phase, hypoxia can develop. Hypoxia is caused basically by upper airway obstruction, that is by a hematoma or secretions, laryngeal edema, hyperventilation related to surgical and anesthesia. It can also be caused by collapse of the lung, pneumonia, or pleural edema. The patient presents to us with sudden chest pain and shortness of breath. Treatment is by administration of oxygen at 15 liters per minute, chin lift and jaw thrush to relieve obstruction. Suction of blood and secretions, drainage of hematoma, treatment of hypoxia, and chest physiotherapy and bronchodilators are also given. The cardiovascular problems are basically of three types. There can be hypotension, myocardial infarction, or arrhythmias. If hypotension is caused, this is due to inadequate fluid replacement after surgery. Or it can be due to vasodilation due to subarachnoid epidural anesthesia, surgical bleeding, sepsis, arrhythmia, myocardial infarction, pulmonary edema, and pneumothorax. The patient, due to loss of blood or due to some volume loss, can present to us with shock. In this, the patient will have cold clammy extremities, urine output less than 0.5 ml per kg per hour, and a low central venous pressure. We will treat such a patient by giving them IV crystalloids and colloids. If in a post-operative period, a patient presents to us with MI, they would be having retrosternal pain radiating to the jaw or to the arm, will be having nausea and dyspnea. Now, the ECG findings can be two. It can be either a non-STEMI or it can be a STEMI. If it is a non-STEMI, what we need to do is, as treatment, is give the patient oxygen, morphine, glycerol trinitrate, aspirin, beta blockers, and calcium channel blockers. If the ECG findings are STEMI, then we have to do immediately coronary reperfusion by percutaneous coronary interventions or by giving them thrombolytics. If the patient presents to us with arrhythmia because of hypotension and ischemia, we need to treat the patient by resuscitating them and maintaining their acid-base balance and electrolytes. Our next problem is the renal problem. In the renal problem, we can have acute renal failure. The causes of acute renal failure can be pre-renal, renal, or post-renal. In pre-renal, the cause can be hypotension or hypovolemia, as the kidney is not getting proper blood supply. This is oftenly seen after surgeries of the kidney. Then next is the renal problems. In the renal problems, there can be nephrotoxic drug usage. By examples are gentamicin, diuretics, or NSAIDs. Or there can be surgery of the renal vessels itself, or myoglobinuria, or sepsis. In the post-renal, there can be ureteric injury or blockage of urethra. To diagnose this, if there is urine less than 0.5 ml per 6 hours, we need to check the catheter if it is not blocked. And then, if that is not the cause, we need to treat hypovolemia in order to rule out pre-renal causes. And we need to maintain the metabolite and the electrolyte abnormalities. If the patient is in stage 1 kidney failure, the creatinine level would increase from 1.5 times more than normal, and the GFR would reduce by 25%. So we need to do the examination of such a patient is based upon clinical examination and any other finding we can receive upon history. If the patient presents to us with UTI, we treat this by giving them proper hydration and bladder drainage and antibiotics. Some of the general problems seen in the post-operative patients are pain. Pain can be fixed or treated by giving them analgesics or opioids. There is also nausea and vomiting. Nausea and vomiting can result in another bleeding point or dehiscence of wound. So in order to treat that, we give the patient H2 receptor antagonists, ondansetron, steroids such as prednisolone, phenothiazine, and antihistamines such as cyclizine. If there is bleeding, we do a fluid resuscitation and we identify the bleeding source by CT or ultrasound to determine the size of the hematoma. If the hemoglobin decreases up less than 8, we treat such a patient by giving them fresh frozen plasma, cryoprecipitates, fibrinogen concentration is maintained, and platelet is maintained above 15 multiplied by 10 power 9 per liter. But be mindful of the blood transfusion, as this can also result in some serious complications such as fluid overload, increase in potassium, severe form of allergy, anaphylactic reaction, and the patient can also receive infections such as hepatitis B, C, HIV, and CMV. So such blood transfusion should be screened before given to the patient. If the patient has been on prolonged bed rest, that can result in DVT formation. Now, the DVT can present to us as a cough, pain, and swelling. In order to ascertain it, we perform a Homan sign. Homan sign is not routinely performed because it can result a thrombus to be converted into an embolus. This sign is elected by dorsiflexion of the foot, which will result pain in the calf. In order to diagnose this, we can also do a venography, a duplex, or a Doppler ultrasound. For treatment of such DVTs, we give the patient IV heparin followed by long-term warfarin. Or we can also, as a precaution, we can give the patient cable filters that is inserted into the inferior vena cava so that it cannot later on result into pulmonary embolism. And also we can give the patient stocking and calf pumps. Then another problem is hypothermia. Hypothermia is due to anesthesia or because of the increased cardiac morbidity and hypercoagulable state. Treatment of such thing is by active warming. In the post-operative period, the patient can also have a fever or infection, so prophylaxis are given, such as antibiotics. Pressure sores can also be caused due to prolonged staying in one position, and there can also be confusion, and wound care should be done. Wound dehiscence occurs on 5th to 8th post-operative days because of disruption of any layer of the wound. So as treatment, what we do is, whenever we find such a condition, we first remove the sutures after 6 to 10 days, leave the wound open and treat it by dressing and vac pump. Vac pump is basically what it does is, this is done if their abscess is present in the wound. We first drain it and create a negative pressure so further abscess cannot be formed there, and this also helps us in suturing of that wound again.